you guys can benefit later on as well. Anyway, assalamu alaikum and hi to everyone. Should we wait a little, like a minute for people to join in, and then we'd start. Just a minute, guys. Sorry, I was just waiting for everyone to join in. Okay, so today's session is going to be brief. It's going to be precise. It's not going to be so extensive, but I wanted to bring attention of everyone towards a common mistake, especially men attending this session or listening to the YouTube video. The problem is monotone. And a lot of times, because it's not marked on your marking sheet, you tend to think that it doesn't make a difference. But the problem is monotone majorly makes a difference. I've said this earlier in my other sessions as well. People fail on a 117, 120, 130. They've passed the number of stations, but they fail like one station by a 0.02 or something of that sort. And why that happens? That happens because of monotone. So I'm going to take you through this, how it affects your result card, and then I'm going to tell you about ways how to tackle monotone and how to make sure you're not monotonous in the exam. So what happens in the exam is you have 8 minutes when you enter the cubicle. And if you start with the basic tone that you have, I am FLA, F2 in medicine, can you please tell me how can I help you? Or I have your results here. I'm sure you're here to discuss your results. Before discussing your results, I have a few things I want to ask, and then we can discuss your results. Is that okay with you? Yes. Now that is the basic monotone. Around 30 candidates every day on the exam go with that tone. Now, tone shouldn't be a problem exactly because the GMC doesn't say your tone makes a difference. But what happens is the examiner zones out from your station. He zones out. He doesn't mark you in anything. He's trying to listen, but he gets distracted because everyone thinks so many things. Am I audible though? Can you guys hear me?
Yes.
Yes.
One person is unable to hear. Is something wrong with their own speaker? Anyway, so then again, how to fix this whole problem? You go through the case, you tell the patient about the management. Is there any concern? I have a concern. Okay, so we'll do this for you, we'll do this for you, blah blah blah. Go through the 7 steps. But by the end, if you see, and the examiner is sitting there, the sheet is absolutely empty. When the sheet is empty, that means that he is going to mark you after you walk out of the cubicle. So when you walk out of the cubicle and you're preparing for the next case, the examiner and the simulator has that 1 minute to decide and give you scores. This is basic, I believe. This is something logical to listen the patient side of the story. the simulator side of the story, and then mark you. The simulator will obviously say, no, he was very basic. He just asked me basic questions. He wasn't different from the rest. He's an average doctor. The examiner himself, who should have been much more attentive, does lose attention, and by the end what happens is you're put in the average category. And though you've done everything, like someone who went to the exam station, the same station, and did the exact same station with tons and tons of energy and had ups and downs of their tone. Oh, hello, Miss Maria. I'm Aisha, one of the junior doctors. I read from my notes you're here for your results. Am I right? Oh, we'll definitely discuss your results and address any concerns that you might have. But, we met the first time. Is it okay if I ask you a few questions? Now that changes everything. It makes sure the examiner is attentive because he'll be like, this person's very different. The same goes for the simulator. The simulator would want to engage with you because this is common psychology fact that if you bring energy to the table, the other person is intimidated by the energy. The other person wants to reciprocate the same amount of energy. The other person wants to engage with you on the same level. So your monotone, and that's one thing, that's monotone. Everything is decided by the monotone. You can either go east or west completely because of your monotone. Monotone also reflects on your exam as if you're not interested, you've already given up on the case, and you don't want to further take the case. It gives that image because whenever I'm taking mocks with people and they have a lot of knowledge, they've attempted the exam 2 times, maybe 3 times, and this is their last time, but they don't have that energy when I'm talking to them. Like I am telling,
last time 4 time they are doing it.
please mute yourself, everyone. In fact, I'll mute everyone. Nobody's supposed to unmute themselves. Okay, cool. So again, they lack energy. And when I say energy that is monotone, it's such a small thing. It's such a small thing to bring an up and down, and up and down to your tone in the exam, to actively, like as if you've had an energy drink and you went to the exam, that sort of energy I'm talking about. And when you don't have that, everything goes down the line. It doesn't mean that only monotone is a big problem. Of course, you have to make sure you're not scripted. You have to make sure you're asking logical questions. You have to make sure your patient understands what you're trying to talk about. Your communication is explicit and open in words. But if you are monotonous and your tone is flat, it will be a very big problem in the exam. And I believe that sometimes, in fact most of the times, it is monotone that makes you appear again and again in exam because you're doing the same things. You have prepared, you are working towards the exam, you know the cases in and out, you know everything. Then what's that one thing that's been the major reason why you're not pushing that score over there, why the score is not going where it needs to go? And that in itself is because of monotone. When you don't fix your tone, you go to the exam, you're doing a consultation with a basic tone, like a basic flat agonal ECG, which doesn't have an up and down. Your tone needs a CPR. Literally, it needs a CPR. And the more you do a CPR on your tone, the better it is. So monotone in both cases. I'm talking about with the usual cases, like someone's there for the results, normal results you're disclosing. Someone is here for their colonoscopy appointment, you have to tell them about another appointment. Someone has Barrett's esophagus and you have to disclose the results. Now, these are all normal things. It's neither bad news nor good news, it's an average news. So I would advise keep your energy up. The way I'm talking right now, I want all of you to have that energy on the exam day. If you can move your arms around while you're talking, keeping it under your own, your own bubble, moving your arms to, improve your communication skills, changing your tone to improve your communication skills, changing your style of talking to improve your communication skills. All of these things make a difference on the exam day. But if you go with a flat line, even if you're throwing good IPS points, that's very reassuring. You told me that. It really, really is a big problem. I can see, Miss Maria, it is troublesome for you. But we have done some tests, we have found the results. You don't need to worry. Do you really think the examiner is going to pass you? No, I know he should be passing you because you did everything right. It's unfair to you. But monotone, and then the amount of candidates they see every day. How do you think they filter out so many people? If everyone passes the exam, how many people are going to come to UK? So they have to filter out things. There's certain things they do discuss, there are certain things that they don't discuss, and this is what I've come across and I've found through my own experience, that monotone makes a very major difference in your exam. I've seen people push to work only on their monotone while they took mocks with me, and they only worked on the monotone and they passed the next exam. So do not underestimate the tone you talk in. It really, really makes a big difference. Do not underestimate the power of your communication skills. It really makes a difference. Do not underestimate when the patient says something to you and you completely say, oh, okay, and move forward. No, you have to acknowledge what they say. You have to pay attention towards what they say. You have to engage with them and see where they're coming from. But again, today's session was basically on monotone and how monotone alone can fix a lot of things. I personally think PLAB 2 is a very easy exam. I know a lot of you disagree with me, I know, and I understand why you disagree with me. But if you see it from my point of view, from the experience I've had, from my own exam, from the amount of people I've tuitioned that they go through the exam and they pass the exam, there are basically a very few things that you need to make sure are fine. The first thing is your introduction has to be spotless. I already have a YouTube video on that. The second most important thing is monotone throughout the case. The third most important thing is engaging with the patient, as in when they say something to you, don't just okay zone them. Talk to them, engage with them, respond the way they want you to respond to their concerns or their worries or whatever is troubling them. And then we have management, and management is not 7 steps of management. Management is addressing concerns. Again and again, I on repeat say that your management is to rightfully justify your words and address the patient's concerns, because if you don't do the addressing concern part properly, you're not being a safe doctor. Why? Because a safe doctor in the GMC or in the exam is not a doctor who saves a patient who's dying. That's just one of them. That's just your Simon case. The rest, a safe doctor is the one who has made sure that the patient completely understood what's going on with him, and the patient is able and capable of making his own decision, and he decides what he wants. That's a safe doctor. A safe doctor is the one who saves himself from making medical errors and getting sued by patients or getting involved in all the law documentation because he didn't say things that were important. He didn't communicate it properly. And we all know that one of the major reasons, even in our own setups that we work, miscommunication is one of the most major reasons why things go out of proportion and things go in the negative way. So communication is very important, that you communicate the right way with your patient. So about monotone, how do we fix it? Now, how do you fix it? So one of the things that I have learned is that when you watch a lot of YouTube videos on consultation, make sure you're watching someone's consultation who's not just shaking the head and okay, okay, okay. Watch consultation videos of CSA, I think I would recommend. Leanne has nice videos on IPS, some other people. So they focus on the tone. Listen to the tone of those patients and try copying that tone. Look at yourself in the mirror, try to copy that tone. If you have a friend of yours or a sibling of yours who's very expressive, including your moms, if they're very expressive, I'm taking that because ladies are usually more good at not being monotonous and they have a different tone. Very rarely have I seen this problem with women. So engage with them, try talking to them, try to learn the way they talk and mimic them. I always tell guys, they're on the exam day, nobody remembers who you were, nobody remembers what you did in the exam. Just be a girl, literally just be a girl, a sweet little girl who who had a lot of energy and who engaged well in the conversation with everyone. Just be that person. Be good with your monotone, because if you go on a tone and there are a lot of okays and there's no up and down in your tone, it's going to cause a lot of problems. So let's say, let's take an example of a case of stroke, a lady who's concerned about stroke. So I'll have a little bit of a water and then I'll do the case, and every one of you can hear that and see how I'm moving through the tone, and that's the way you have to work on the tone. Right, so someone shows up and says that, doctor, I am worried about getting a stroke. My mom had a stroke, my aunt had a stroke, blah, 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 blah. So thank you so much, Sarah, for telling me that you're concerned about strokes. And I'm actually here to help you today about that. We'll sort your confusions out. We're going to discuss them. And even then, if you have any questions, I'll try to get my senior on board and we can do whatever we can about that, right? Okay, so before we even start, I'd like to ask you a few questions to see how much you know about strokes and if you've had any, because sometimes people can have a stroke without knowing that they had one. So then you go through the questions of stroke, right? Past medical history, allergies, medications, you ask about her lifestyle and she tells you she smokes 50 cigarettes, she's an alcoholic, her diet is really bad, and her exercise is zero basically because she doesn't work, right? So then you're going into the management section, and throughout these things you're not telling her, well, that's not nice, that's not nice. You're just telling her, that's good to hear. Okay, what do you do for a living? So you're a banker. Oh, I see, that does include a lot of sitting, I believe. Yeah, but that explains why exercising as well. Yeah, so constantly, with a yeah, with a these sort of things, you're constantly engaging with the patient and you're not being monotonous, like yeah, okay, okay, thank you for telling me all of this. Okay, no, we're not doing that. We're engaging full on with the patient, engaging with the patient, talking to the patient. So then afterwards, what happens is that you enter the management section. So I'd examine you, Miss Sarah, a little bit, just check your vitals to make sure you're fine. And now coming to stroke, you said you wanted to know about stroke. Now, stroke is something when there's injury to certain part of the tissues in the brain, and that can happen when either a vessel is blocked or a vessel tears. When that happens now, so that part of the brain dies, and whatever part it's supplying in the body, that becomes weak. Like I asked you earlier about these questions, that's the symptoms that you experience when it dies. Am I making sense so far? So if you guys can hear me, my tone is constantly going a little bit up, a little bit too low, and I'm engaging her as well. After a few phrases, when I have gotten a point across, I'm checking if she understood what I said. Then you go with, do you have any concerns so far? No, Roger. Yeah. So you asked me, how can you reduce your chances of getting a stroke? And that's very important. There are certain things in your lifestyle that I picked, and I would definitely want you to pay attention towards them. Would you want us to discuss them? Yes. Okay. And then you get into the lifestyle questions. You tell her, well, smoking in itself causes narrowing of the vessels. They can cause blocks in the vessel, like I said, in the brain, and that can increase your chances of stroke. So now would be a very good time to think about quitting smoking. What do you say? Oh, I'm more than happy to help you if you need any help from our side. So this is how I want you to communicate in the exam. And if it looks difficult, well, learn it. Learn it if you have to pass. You need to learn this way of talking, because that's the only way it's going to save you. Like monotone, I'm not saying like go full on the way I am, because I do understand a lot of people don't have the energy and they'll be exhausted and done and dusted within seconds. But I do have a lot of energy, I agree. And I do talk like that to all my patients the whole time. I don't know why, maybe I do have a disorder or something of that sort, but I do have energy. But at least try to go somewhere there, be a bit energetic with your patient. So even if you have a sick patient, You have to show your energy. Oh dear, I can see you're really unwell. And I am going to be asking you a few questions and making sure, we work this pain out, okay? And then you start asking questions. So you can ask the questions that way as well. Monotone doesn't mean you have to be high like maniacs. I'm just saying don't be monotonous, as in talk, but engage with the patient. Like as if you're talking to a friend, like as if you're talking to a guest in your drawing room who you like, not the ones you dislike, because sometimes the ones we dislike, we're like a whole monotone with them, like get out of my house. So no, someone you like, someone you want to talk to, someone, a friend that you really like, and you're talking to them, and your monotone has to go away. On the exam day, please don't be depressed, don't be upset, because that can affect your scorecard, and don't be stressed. So any questions? That's it, I'm done. Now I take your questions. We don't have questions, really? That's interesting. Okay. I'll unmute you all.
Doctor, I have a question, if I may.
Sure, absolutely.
Yes, so how about in breaking bad news? So how do we approach? How do we introduce ourselves? Because we cannot enter and say, oh, hello. We cannot do like that energetic voice.
Yeah. So the whole thing is that what we're thinking here is that we think monotone is something that has to be the heights. Monotone is something that you even have to go to the lows, like, hello, I am Aisha, one of the junior doctors here. I'm so sorry, Miss Maria, about your husband and the way he was brought to the hospital. Are you comfortable for us to talk? Now, this is not monotone, this is low tone. And I'm going into a low tone to engage with this patient. Monotone is like, hi, Miss Maria, I am Aisha, one of the junior doctors here. How can I help you? I'm really sorry to hear about your husband. Can you tell me what exactly happened? So that's what I'm trying to tell you. Like, go to the lows, go to the highs, but don't stay on a mono, because that will be like putting yourself into the average category. Am I making sense?
Yeah, doctor, thanks.
Welcome.
Dr. Aisha, I have a question. Basically, not related to monotonous, but it is about the last discussion which we did. You told us to make a unique introduction. I just want to, share a phrase with you. Please tell me if it would be the fine introduction or not. Is it okay?
Mm-hmm.
Okay, so can I say like this, like reading the name from the notes? Hello, Mrs. Sarah. I'm Tara, one of the doctors here in this department. I can see from my notes that you have some concerns.
Miss Tara, you're monotonous. Come on, bring it with a good tone. I'll hear it then. I'm
Okay. Okay, let me try. Hello, Miss Sarah. I'm Tara, one of the doctors here in this department. Could you please confirm your name and age? Okay. So I can see from my notes that you have some concerns related to your vision. Please tell me, how can I help you? Does it sound fine?
That's perfectly fine. Absolutely. Yeah.
I just learned this from you right now. Thank you. Credit goes to you. I love you for this. Thank you.
I'm more than happy. About introduction, people are asking me how to make a good introduction. So I do have a YouTube video. I'll post it on the groups eventually. So
Okay.
See the introduction one there. I'm going to upload this one as well, the one on monotone. And like this, some days we pick snippets of things, and we're going to discuss them so that we know that we are not ignoring important things which aren't spoken about commonly. These are not common things people pick up. These are uncommon, and they can majorly bring your score down. Okay.
Okay, thank you.
You're welcome. Anyone else?
Doctor?
Yeah.
For the men that we cannot act, we don't know how to act. So how to improve this point?
This whole lecture was Two men, me addressing men and telling them fix your monotone. Okay,
Yes, I know, but what else can we do? Can we try?
it's a very important thing. What else can you do? So it's not like I didn't struggle with monotone. I did struggle a lot with monotone as well, because I did have monotone as well. So what you can do is, and what I think is very insulting to your own self, and you literally see your mistakes, is when you're doing a case with someone or any partner of yours or any friend of yours, record yourself on the Zoom session. So when you record yourself after practice, just see your performance. And when you see your performance, you see, like, you're literally slapping yourself from the screen that what the hell was I doing there? So you see your monotone and you realize that I have to change my tone here. This wasn't the right phrase to use. This is a better phrase to use. This wasn't the right way to talk. I should have escalated my tone, or, should have gone to a lower tone. So I think that's one of the best things that works for me, has worked for me, and I would advise it to all the men as well. And sometimes I do it in the mock as well. If people are not improving, I start recording them, and then the next half of the mock is me showing them, like, look at this, what have you done? And it's very, very insulting and it's very disgusting, but it works. So I think go ahead with that. That would help.
Thank you.
Welcome.
Thank you.
Hi, doctor. I had a question. In the Simman and examination stations, how should we maintain our tone so that it is still engaging enough?
The same way you have to maintain your tone, the same way. Another thing about Simon and Simon cases basically is that please do ask for help when you have an unresponsive patient or a patient who is vitally unstable. Always, when you're there, talk to the patient yourself.
Doctor, you're not audible.
I know. So now I've put that person on mute. Anyway, so when you enter the Simon case, I have an ALS course coming up. As a junior doctor, I'm doing that ALS course. And we've been taught about all the 6-7 scenarios that come in the GMC building. And in every scenario, there is an algorithm, and the algorithm says, shout for help. So when you enter, you introduce yourself, you listen to the person is unable to talk. Hello, Mr. Henry. Mr. Henry, can you hear me? Okay, I'd like to call for help, and I'd like to call the crash team, and then start working on the patient. Never take the patient alone. And if you start working on the patient after calling for help, I'm pretty sure it's going to spike your score up by a 3.
Oh, okay.
Okay, and with the same way, with the same tone. Oh, Henry, can you hear me? I'm here for you. I'm going to help you. I can see your vitals are unstable. Still the same way.
Okay. Because I was just, concerned that what if I sound panicky in that situation?
When anybody would be panicky in that situation, don't you think doctors do panic? So it's normal, it's fine. But
okay,
if you're doing things properly and your tone is a little high and you're communicating with the patient, then that's fine. It won't be in the panic category, don't worry.
Thank you, doctor.
Welcome. What should be posture and eye contact? So the eye contact has to be there, I believe, like 24/7. Because you should not staring in the eyes because you have beautiful eyes, sort of eye contact, but every time you're blinking, you're nodding your head, and that sounds quite stressful. So you look at their one ear, 10 seconds later, then you look at the other ear, 10 seconds later, and then again you make eye contact. That's how the eye contact should be. The posture should be a normal posture, like how you're supposed to sit, like normally in a consultation, like, I am the doctor here today, that sort, not a very, oh, I'm scared, I don't know whether I'll pass or fail. I've already decided that I will fail this one because it's too much stress. That sort of a posture is horrible. Hand movements, too many hand movements, no, but a little bit, a little bit of a high, a little bit of a low. When you're moving your hands to explain a certain condition, you touch your chest and you say, so there's something going on with your heart, or you touch your temple and say, I think your arteries of the temple over here, they are inflamed. Nothing is wrong with that. It's perfectly fine if you carry the hand movements. Don't sit like a robot there and carry the consultation. Be yourself, be natural.
Hello.
So,
Dr. Aisha, I want to ask a question.
yeah.
Actually, I have this problem with my monotone. Whenever I practice with my friends, they always say that I'm monotonous. So, apart from recording myself and checking what mistakes I have made, is there any other way to improve this thing?
I've told you, either record yourself, listen to consultation videos on YouTube,
Oh,
like write down CSA consultation, write down Leanne consultation, write down PLAB2 consultation, and only listen to them if you see an up and down in their tone. Like if you see them like they're just like, okay, so now I'm going to do this for you. I can see you're a bit worried. If anyone's talking that way, shut it down immediately. Don't listen to them anymore, because
okay.
that's not how it is in the exam. In the exam, you have to have ups and downs of the tone. If I find a few videos, I'll post them on the groups as well, so that they can help you all.
Okay. Thanks a lot.
You're
Thank
welcome.
you.
You're welcome.
Doctor, can I ask you another thing, please? That it's not really directly related to this, but it popped up in my mind, and I want to ask. Can I?
Sure, we have 8 minutes, anything in 8 minutes, and afterwards the session's going to boom, disappear. Okay, cool.
Okay, so when we introduce ourselves, should we emphasize that I'm a junior doctor, or should we say only that I'm a doctor?
I am a junior doctor.
Okay, because I heard like someone say that it's not very convenient because they will say that, okay, just call me a senior doctor, not a junior one.
Never say that, bro. They're sitting there. The exam is designed for junior doctors. Why do you think they will say that? They don't say anything of that sort. Whoever says that, they're just trying to scare you. Don't worry.
Okay, thank you.
You're welcome.
Doctor, is it okay if you can do a session about management, like points like you said about introduction?
Management, yep, sure. Some when I'm free and I am in a good mood. Yes,
In the near future?
I will. But I've covered management. Like management depends case to case. It's different from each case.
Mhm.
So I've covered all of these things a lot of times in my course. So when someone asks me, can you do management? So I'm like, might as well take my course and not let me talk. But I will do a short one. Don't worry. I'll do a short one
Okay,
sometime.
thank you. Thank you very much.
Don't worry.
Dr. Aisha, regarding involving of the senior, what do you think? Because this area of debatable opinions. Some of them asking, saying that it would be better to show the examiners that you are a safe doctor, so you involve your senior, and some of them saying that it's better not to involve him in any case. What do you think about that?
Dr. Shukarela Muhammad, I would say.
Yeah,
Dr.
yes,
Muhammad,
yes.
the thing is that with the senior, as this is a junior doctor's exam, remember that. And in the GMC or in the NHS, you cannot function or work without your senior's consent. He has to be on board with you. If you do anything at all without his consent, without his, even up to the level of prescribing a medication which you haven't checked with your senior, you're liable. You can be sued if it's something wrong. You can go through trouble if the patient is not, the patient, it reacts on the patient and all. So what I said earlier, you have to be a safe doctor. And here, a safe doctor doesn't mean only that you're a safe doctor for the patient and taking care of the patient, but also you're saving your own self from trouble. So you have to make sure like your position is safe. So I would advise that always keep the senior there. Always keep the senior there.
Mhm. Mm. I get you.
So we have another question from Dr. Ramya. What if once we enter, the patient is shouting from pain? How can we proceed? Nope, don't offer painkillers. Never offer painkillers. Even if the patient is about to die from pain, don't offer painkillers. Tell them thank you so much. No, not thank you. Sorry. It's just zoned out. You tell them that, oh, I can see you're in a lot of pain and I know you need pain medication. I promise you, I will give you pain medication. Can you bear with me for a few minutes until I understand where the pain is? I examine you and then I'll quickly give you a painkiller. So that's when you give the pain medication, not before examining, not before knowing the full history of the patient. Do not offer. Can we say dare and love to our patient? I wouldn't advise love. I would advise dare. But if it's the same gender, like a girl can say to other girl, I wouldn't, and an elderly, you can say, oh, dare, that sounds a lot. But love, no. Love is an ambiguous term. I wouldn't advise you to use that. Dare, absolutely, you can use that. With anyone, a child, middle-aged person, senior, same gender, opposite gender, dare is a very nice word. You can use it. Oh, we have a very big question. Let me see. Would you suggest that we should practice with multiple people or just focus on practicing all your stations, the study partners one has? Because sometimes you don't even know what to speak. That is, there are certain stations for which you must need to go through notes, like transgender patients and all. I haven't taken any academy. So for me, whenever there was a station that was new, NHS website was my go-to place, and discussing over the groups, it really helps you. So you can go to the NHS website. It keeps you very updated with everything that's coming on. So NHS website is what I would advise you to go through, and go through it with your partner. I don't advise multiple partners. I think stick to one, but you both should be genuinely honest with each other and giving each other honest feedback. Not like, okay, yeah, you were really good, now it's my turn, and then you start talking. That's not fair to the other person, because most of the times when I'm taking a mock, I mostly hear from people that, Dr. Aisha, you're very critical. My partner thinks I'm fine, I'm doing really good, so it's fine. So that is trouble, because the partner is just trying to get rid of you and using you and like trying to practice more. So practicing more is not the goal. Quality practice should be there. And if your one partner is good enough, he's good, he's critical, he's assessing all of these domains for you, you stick to them. And if they're not doing that well, then you change your partner. But I would advise stick to one partner whose exam is around your date. That really helps. Can we use sir? Sir is not a very good term. No, sir is, in the UK, sir is only given to a man who's very qualified and, has earned a Nobel Prize or something of that sort. So don't call them sir. I came here and I started calling people sir, and then my consultant was like, just call me by my name. Don't call me sir. So if he minds it, imagine the patient who's nothing. So don't call them sir. Call them by their name.
Doctor, I had another question, if you don't mind.
Sure.
I was wondering how to manage the time during history taking, because my history taking goes up till the 6-minute mark usually. Because, in between we have to do the IPS and we have to be patient. We cannot rush the simulator. So I was just wondering how to move the data gathering along.
It gets better with practice, my friend. The more you practice, it will squeeze to 4 minutes. I promise you.
Oh, okay. Thank you.
Welcome. Guys, the time is up. It was a very nice session, and I can't take more questions. I have explained the tone pretty much. I hope those who have missed, they can hear it on YouTube. See you other time. Bye-bye. Take care, everyone. Allah Hafiz.